Shall we proceed to the question and answer
session? No, I've got one more session for.
I apologize.
Okay?
I'm way in advance.
Okay.
My apologies, Dr. Lee.
Okay, then in this session, I will discuss the indication of direct myolysis. It takes about 10 minutes. My presentation in the following order. And let me begin with RF-EM ablation. RF-EM ablation target is endometrium. But if you ablate the myometrium of the subendometrial layer together, the effect increases. Treatment time is approximately 10 minutes, and it gives superior result in hypermenorrhea and DUB than medical treatment. Basically, myometrium is not ablated, so it does not work on dysmenorrhea. The symptoms caused by the mass effect are unaffected because there is no size reduction effect. So the target patients are those who do not respond successfully to medical treatment, among those with severe hypermenorrhea and DUB without mass impact. This is EM ablator, and the blunt tip of the EM ablator allows it to be inserted like a Hegar dilator. This is a case of EM ablation. The patient was 43 years old with hypermenorrhea but without dysmenorrhea, and her hemoglobin level was 8.1. In the past, Mirena was inserted, but it has been removed due to a continuous irregular vaginal bleeding. The ultrasound check after the visit showed mild adenomyosis, and there was no specific finding in the endometrial biopsy. As the patient wanted to stop her period completely, RF-EM ablation was chosen. First, make sure that the EM ablator is inserted in the correct location. Okay. After insertion, ablation is respectively done on the 6, 9, 3, and 12 o'clock direction for 2 minutes each. When you first start the ablation, you won't notice any change in the ultrasound, but you will see echo change over time. Next, ablate 9 o'clock direction. After ablation on one side, it is better to wipe off the carbonized tissue on the tip and insert it again before ablation in a new spot. And next, ablate 3 o'clock direction. As the tip of EM ablator is blunt, so it is very safe and easy to insert the tip in the correct location. So EM ablation can easily be performed even by beginner. Next is 12 o'clock. EM ablation gives superior result in hypermenorrhea, DUB, and medical treatment. But basically, myometrium is not ablated, so it does not work on dysmenorrhea. check if the ablation is sufficient and complete the procedure. So we confirmed complete ablation around endometrium with a CT scan 1 week after surgery. Next, I will explain the indication of RF myolysis on myoma. Target is myoma and surrounding feeding vessels, and it takes about 20 minutes. The effects on improving symptoms such as dysmenorrhea, hypomenorrhea, and AUB is very excellent. And as for symptom relief by mass effect, satisfaction is relatively low compared to the surgical resection. According to the data from various papers, the average treatment target is 5.2 cm myoma with symptom. And the mean diameter after 12 months is about 3.5 cm. Among patients who have symptoms such as dysmenorrhea, hypomenorrhea, and AUB, but do not respond to medical treatment, the patient group without a large mass effect enough to consider hysterectomy should be selected. Next, let me talk about RF myolysis on submucosal myoma. Target is myoma and feeding vessel, and it takes about 10 minutes. Most submucosal myoma show severe symptoms such as dysmenorrhea, hypomenorrhea, and AUB compared to the size. Therefore, the submucosal type of myoma is the best indication for RF myolysis. In particular, myoma over Lastman's classification grade 2 is often difficult to remove at once by hysteroscopy alone. Therefore, in this case, performing prompt or delayed hysteroscopy after first performing RF myolysis can be a good treatment to preserve the uterus. In the case of large size or submucosal myoma in the substantial intramural part, myolysis is a safer and more effective treatment than hysteroscopy. In addition, delay or prompt hysteroscopic myomectomy after RF myolysis can be performed with reduced bleeding during surgery and efficiently remove the mass. Next is adenomyosis. Target is adenomyosis and feeding vessels and endometrium. It takes about 30 minutes. Among the adenomyosis patient group, good result can be expected in the case of dysmenorrhea, hypomenorrhea, and AUB, and pelvic pressure symptom caused by mass effect. The satisfaction level can be decreased. It cannot be expected to have a significant effect on the pelvic adhesion symptom like dyspareunia caused by concomitant endometriosis. While a safety margin is secured, treatment with the aim of sufficient ablation of the entire uterus can result in excellent result. This is because symptoms may originate in the region other than the adenomyosis tissue seen by ultrasound. As adenomyosis tissue contains more water than myoma tissue, so higher thermal doses are required for treatment of adenomyosis compared to the myoma. It is important to note that myoma is surrounded by capsule, so the heat tends to be confined within the capsule, whereas adenomyosis does not have capsule, so the heat may pass out of the uterus. Special care should be taken if there is pelvic adhesion caused by concomitant endometriosis, since the heat could travel outside of the uterus and cause injury to the adhered valve. Among patients who have symptoms but do not respond to medical treatment, and the patient group without the large mass effect enough to consider hysterectomy and without pelvic adhesion-related symptoms should be selected. RF myolysis with LNG-IUS combination treatment can reduce the recurrence rate after RF myolysis in patients with symptomatic adenomyosis. So thank you for your attention.